Good evening, and welcome to Doctors on Call. I'm Dr. Ray Christensen, faculty member from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School. I also am a family physician at Gateway Family Health Clinic in Moose Lake, Minnesota. I'm your host for our program tonight on upper GI problems. And please remember, the success of this program is very dependent on your questions of the audience. So please call in your questions tonight or send them in email to our address at ask@pbsnorth.org. The telephone numbers can also be found at the bottom of your screen. Our panelists this evening include Dr. John Reich, a gastroenterologist with Essentia Health, Dr. Umar Siddiqui, an internal medicine specialist with St. Luke's Internal Medicine Associates, and Dr. Jason Wall, a family medicine physician with the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Alex Higgins, Stewartville, Minnesota, Andrew Midnoff, Lowry, Minnesota, and Sean Morris from Maple Grove, Minnesota. And now on to tonight's program on upper GI problems. I'd like to start out, I think, probably just letting you guys introduce yourselves. Jason, you want to tell us just a little bit about your work at the residency and what you do?
Sure. Thanks, Dr. Christensen. When you complete medical school, you have to choose your specialty: pediatrics, internal medicine, surgery, obstetrics. If students choose family medicine, they come to our program here in Duluth for 3 years, where we work at both hospitals, and they learn how to take care of basically people from cradle to grave. So we do pediatrics, adult medicine, deliver babies, and take kind of its continuity. So we take care of people in the hospital, outside the hospital, and we try to be the proverbial general practitioner.
Good old GP.
Yeah.
That's where I started. Dr. Siddiqui, yourself.
I'm an internist at St. Luke's in internal medicine, but I also do addiction medicine. I'm board certified in that, and I recently just passed my boards in obesity medicine, so I kind of do that now as well. And,
Dr. Reich?
Yeah, I'm a gastroenterologist at Essentia Health, focusing on all kinds of GI issues, but upper GI, reflux, Crohn's disease, ulcerative colitis, several different things. I did my medical school here in Duluth, and happy to be back. It's a great place.
Dr. Wall, I think we'll start with we've already kind of talked about some of the things that Dr. Reich does. So let's talk about the esophagus and reflux and some of the medications. We talked about the PPIs earlier. Fill us in a little bit.
Sure, thanks. I find that, in the course of a day, we become used to a certain vocabulary. We throw around all these terms: EGD, PPI, NSAID, and these are, PPI stands for a proton pump inhibitor, NSAID stands for a non-steroidal anti-inflammatory drug, and EGD is an esophagogastroduodenoscopy. It's a camera down the throat. So where these all come together is that, if you have a problem in your stomach, such as an ulcer or too much acid production, reflux, a proton pump inhibitor is a class of medication that can affect the parietal cell, which is a cell in the lining of the stomach that exchanges potassium and hydrogen and makes your stomach acidic. Acidic stomach is the normal state. Prevents, it starts the digestive process. The proton pump inhibitor will stop the secretion of acid into the stomach pretty effectively, almost, completely. We use that for people with ulcers and people with conditions that could lead to bleeding, where the acid could irritate that and cause bleeding. And so it's a very effective medication. There are many out there, both over-the-counter and prescription, and you probably know many of them from the TV ads. But very effective medication and kind of a mainstay of our treatment for gastroesophageal reflux and other conditions. So,
Dr. Reich, do you want to add to that? One of the questions that just came in is, are there alternatives to the PPIs to treat GERD also?
There are, and this question comes up in my practice nearly daily. And the question, one of the questions has been the safety of these PPI medications, especially long-term, and we can talk about that too. But as far as alternatives, there are less potent acid-reducing medicines. They're called H2 blockers that they don't turn off the acid quite as much, but they work fairly quickly, and for most people are fairly effective. Famotidine is the most commonly used over-the-counter version of that. We do talk a lot to people, especially if heartburn or reflux is their main symptom, about lifestyle changes such as weight loss. Some folks need to have their torso elevated a little bit at night so that gravity keeps acid down. A lot of this is because the sphincter muscle that controls acid reflux in a lot of people is a little looser than it's supposed to be, or they may have a small hernia inside that allows for more acid to come up. But so sometimes lifestyle modifications can be quite helpful, these H2 blockers. I've been talking to some people about even a supplement called DGL. It's called deglycerinated licorice. It's a black licorice supplement that seems to help soothe the stomach sometimes if people are very opposed to taking those proton pump inhibitors. I will say that I feel in general they're fairly safe to take, and in the long run, if folks are getting enough vitamins and minerals, whether it's through multivitamins or diet, calcium and vitamin D, generally there's very minimal risk to taking them, but there are some alternatives.
Dr. Siddiqui, do you want to add into that any?
I think that's pretty much covered most of it.
So the question to go along with that is drinking hot drinks regularly bad for your throat?
Is drinking hot drinks regularly bad for your throat? I mean, I don't think it shouldn't be bad as long as not scalding hot. But drinking hot tea and coffee should be okay for your throat. It can even help soothe a sore throat if you have one.
Family doc, anything you want to add into that?
I think it's benign, and unless you have some other irritants such as chewing tobacco and other things that can cause chronic inflammation in the mouth, it's pretty harmless.
Acid reflux seems to get worse for this person lying down at night. Are there, other than, and you've already done this, some of this, John, in discussing this, are there other habits like eating earlier that might be helpful?
Great question. And again, yeah, we talk about this quite a bit, but we feel that having food in your stomach when you lay down at night is a fairly significant risk factor for reflux. And most of the reflux that occurs in people are times when often you don't feel it when you're laying down or sleeping at night. And so I generally recommend people try to avoid eating even just little snacks within a couple of hours of laying down. One of the other things that I tell people about that isn't super expensive, not like buying a big adjustable bed, is you can take 2x4s or bricks or some cinder blocks and actually put them on the floor under the bedposts, raise it up about 4 to 6 inches, and that way your whole bed is at a little gentle slope, but you can still roll around. If you're like me, you're always moving at night when you're trying to sleep, but then you still sort of have a somewhat natural position, but that gravity does help keep things down.
Dr. Siddiqui does GERD, which is gastroesophageal reflux disease. I thought we probably ought to say what GERD is. Is that a risk for esophageal cancer?
I mean, it can be, again, as we just discussed, the lower esophageal sphincter may be looser for some people, and if that does kind of consistently over time, the acid gets into the esophagus, it can lead to changes in the lining of the esophagus, which can eventually, if going untreated, could lead to cancer.
John, do you want to follow us through with that? So I imagine an EGD is where we go with that. And how often? A couple minutes on that.
Yep, so the EGD, or esophageal gastroduodenoscopy, as Dr. Wall pointed out, is a small camera, about the diameter of a pen that you write with, in your mouth and down into your stomach and your small intestine. And one of the main reasons we do this is for people who have reflux. And to add on to Dr. Siddiqui's point, chronic reflux can change the lining of the esophagus. It can actually adapt and mutate and turn into this thing we call Barrett's esophagus, in which the esophagus actually almost turns into stomach lining. And because it's trying to adapt to that acid environment that it's not supposed to see. But over time, that Barrett's esophagus, those cells can continue to mutate and potentially turn into precancerous and cancerous cells. And so one of the reasons we do the endoscopy is to screen people for that, check for that, and try to identify why potentially they are having the reflux issues.
And also, too, this comes up a lot in our clinic, is that once you've been diagnosed with that Barrett's, I think there's a pretty regular follow-up where they want to do EGDs, it's like every 1 year, 3 years, something, to make sure that we're surveilling that it's not progressing.
It's true. We do keep an eye on that depending on how much there is and what the cells look like under the microscope. Typically anywhere between 1 and 5 years that we keep an eye on that.
Dr. Siddiqui, one of the questions that's come in is food getting stuck in the throat. And this person, it was after nights of heavy drink. Dad has the same thing, wondering if it's genetic. So this is the son writing in and asking, or if it's related to alcohol. And is there something they can do about home prevention of this? And I think just push into that and move into maybe some symptoms of esophageal cancer. We'll mix that in too.
I guess symptoms of esophageal cancer would be.
I'm thinking difficulty swallowing.
Difficulty swallowing, that could be one cause. Another cause that's commonly seen is like achalasia, where the muscles in the esophagus that kind of help the food contract and go down. They don't. The nerves don't contract the way they should, and the food can get stuck, typically solids. That can be treated. There's different things they can do, dilations and other procedures that may help with that. But an EGD is what would be helpful in diagnosing any kind of narrowing or those kind of things that you would see.
I don't know the answer. Is this? Do you guys know? Is it genetic? Is there a genetic predisposition here?
I don't think so. I think that so alcohol relaxes that sphincter muscle. It also can actually be directly a little bit irritating to the esophagus, similar to acid. And so the combination of alcohol, food, and the acid and the loose sphincter, what I see in a story like what I'm hearing here is that over time, the irritation from these episodes actually can cause narrowing and scarring of the esophagus, called a stricture, that usually is benign. But if you're getting food stuck, that is something that we probably need to look into and probably need to take a look with the camera just to be sure there's nothing more going on. But most of the time, it's really just sort of direct irritation from the alcohol and the acid.
And this question has come up several times about the feeling that something is stuck in your throat or difficulty swallowing. And what you're really saying, at some point along the way, that should be evaluated. Go see your family doc and probably a GI and have a look in there. Jason, you want to add into that?
I really appreciate when the GI physicians do an EGD, because it's a pretty quick and simple test, and it gives a lot of information, especially if, a picture's worth 1,000 words when somebody's saying that they just have this sensation that food's getting caught. And it could be something as simple as a stricture that from reflux, but it could also be cancer. And so the sooner we know about that, the better.
The other thing we can do on an endoscopy is actually stretch things out a little bit. And we can do what's called a dilation to actually help that food go down. And we're seeing lots of young people who actually have an allergy type condition, and I want everyone at home to memorize this phrase. It's called eosinophilic esophagitis. But it's actually a long-term kind of chronic allergy where the esophagus gets narrow and people get food stuck, and that's a symptom or a disease that it's not, doesn't shorten anyone's life, but it does need to be addressed. People generally need to change their diet or be on different medicines and have these things called dilations. So getting food stuck and things not going down is definitely something we take seriously.
Nissen fundoplication. Is this a helpful treatment for GERD? And any ideas on the long term? Does that have to be redone or looked at again? And I don't have an answer. This is a question. John, I look at you. I don't know.
Yeah, well,
Siddiqui,
so Nissen fundoplication is a surgery in which the top of the stomach is actually taken and wrapped around the lower part of the esophagus to tighten that lower sphincter muscle so reflux can occur. It's very effective. The numbers are not perfect as far as about half of people, maybe after 5 or 10 years, maybe need to be back on an acid blocker. There are some downsides to any surgery. Oftentimes people can't vomit after they have this surgery, which is fairly bothersome for people. Sometimes you feel a little more bloated with it. In general, it's effective, but it is surgery, and there's all kinds of new techniques actually coming out, even one that you can do through a scope. There's a little magnetic device that can be placed surgically that goes around the bottom of the esophagus to tighten that sphincter a little bit, that can be removed if it doesn't work. And so while Nissen is still a fairly common surgery, There are some sort of alternatives that we're sort of moving toward that are a little bit sort of less invasive and don't change your anatomy as much.
Thank you. Jason, what might cause someone when they're eating, let's go back through this. Their difficulty swallowing, something gets stuck in the throat, they can't swallow, they can't breathe. Talk about that situation just a little bit, the Heimlich.
Certainly, excellent question. So, having obstruction, that's conceivably where food has gone down, the trachea and is no longer, people can't ventilate, so they can't move air in and out. It's a medical emergency, and the Heimlich is a forceful blow right in the subxiphoid region to create intrathoracic pressure to expel that material from the airway. So yeah, it's a medical emergency, and another important thing to do is with your finger, sweep the person's back of their throat for anything, and it can be done standing. It can also be done with the person laying on the ground, and a strong application of pressure right in the subxiphoid region. I've never seen it done. I don't know if any of my colleagues here have, but I think the important thing with choking is to recognize it and to get help, and the Heimlich would be a first-line maneuver.
And when you're an old person, cut your meat up and eat small amounts, and all of
Chew better.
Yes.
Chew better.
I've only ever seen it in movies.
Yeah.
Yep.
Yeah.
Dr. Siddiqui, could you talk about stomach polyps just a little bit?
Stomach polyps, that's a growth of the stomach lining that can be precancerous. Again, would be from increased acid production. If you have different things like gastritis, Helicobacter pylori, different bacteria, different causes of stomach polyps that could be precancerous if not caught early enough. So that's when you would be noted on an EGD, which would go in biopsy and see what that shows.
And Jason, because this kind of falls in our area a little bit, gastric ulcers, H. pylori.
So there's a bacteria that can invade the lining of the stomach, and when somebody comes to us with chronic burning pain, our list of possible diagnoses would be ulcer, infection with this Helicobacter pylori, and then of course some other conditions due to medication use. Commonly, people take a lot of ibuprofen, non-steroidal anti-inflammatory drugs. Those can lead to some irritation of the stomach lining. Poor nutrition can lead to some breakdown of the stomach lining, along with some tobacco use and other things can cause further irritation. But as far as the Helicobacter, when we're going through and trying to figure out what might be causing this pain, if there are other risk factors, the person's not consuming alcohol, they're not using a bunch of ibuprofen, at that point we often refer to our colleagues in gastroenterology, and there are some tests that you can do to look for Helicobacter pylori. They're not perfect. We'll do those tests. If they come back, then we'll go ahead. It's a cocktail of medications you take for a couple weeks to treat. But if that doesn't, then the gastroenterologist can go in and take a biopsy of the stomach lining too. And when you look at that with a microscope, they can identify these organisms in the lining too. And it's very endemic, common in certain parts of the world, but I see it, on a regular basis in our practice here too.
Does H. pylori, and this is for all of you, does H. pylori increase the risk of stomach cancer?
It does, and in fact, it has been implicated potentially as so stomach cancer worldwide is the second or third leading cause of cancer death, and it's because H. pylori, partially because H. pylori is so endemic in particular Southeast Asia, where stomach cancer is very common. They have very strict screening programs and things for it. And so it is something that even sometimes if we find it incidentally in the stomach, maybe it's not causing any symptoms, often it is recommended to treat it because it is considered a carcinogen.
We talked earlier, and I think we need to just go back. These long-term medications, when I was in medical school, we worried about bleeding, obstruction, perforation, and pain for ulcers. And then Tagamet came. And the world has changed from that point. So I'm really old. So the long-term use of these medications, in the beginning it was 3 weeks or a month or whatever, and there was always a break. Now we're perpetually on them. Do PPIs and these other medications increase the risk for Alzheimer's or other illnesses or not? And these are the questions that are floating in here right now. As for the panel, you can all jump in.
I get the question so much, but the studies on this, the population studies, I don't want to bore anybody too much, but there's always conflicting data. One study will say there's a slight increased risk of dementia, and then a larger, maybe better quality study will say that no, that's not true. And then another one will say maybe there is a little bit of a link. And we don't really understand if these drugs do cause that, what the reason that would be is. And so my general approach really with any medicine is if we can find alternatives, use the lowest effective dose possible, that like we talked about lifestyle modifications or less intense medications, sometimes surgery if it's heartburn or reflux or things like that. But in general, it's a risk benefit with any medicine, and the risk, from what I can tell from reading the studies, is that the risk is extremely low if there is a true link to those two things. And so we always have the discussion, but usually if someone really needs to be on these medications, it's to help their quality of life and prevent cancer, and it's usually we feel like the benefits of these do outweigh the risks.
I agree. I feel like the more immediate effect of their day-to-day discomfort with eating, quality of life, enjoyment of their life in general kind of gets impacted. They get benefit from taking the PPIs or Pepcid or whatever they're taking, where Alzheimer's, there's no confirmed risk. I feel like the immediate risks the benefits outweigh the risks in the long run.
A follow-up, are there any vitamins or supplements or foods that are beneficial for upper GI health? Great question.
But
A plant-based diet is going to be beneficial.
Mediterranean.
Yeah.
Stuff that's more easier to break down. Obviously, if you're eating more complicated food, a lot of meats that are harder to break down, your stomach's going to make more acid to break down those things, which could increase, the stomach upset and stomach pain.
Anything with a higher, nitrate, some of the smoked meats, and and certainly just from a functional, I enjoy spicy food, but if you have a diet of chronic, very spicy food, that can be harmful too. Just can lead to some chronic irritation.
Is that true? Because the argument is that the spice or the peppers are good for you. I don't have an answer. I'm just here. You guys sit.
Recall if it's cayenne pepper. I saw a study not too long ago that suggested that maybe some spices have a little pro-inflammatory effect, although most foods that have spice in them, we're not talking about spicy Doritos and things like this, but like actual peppers and real true food plants and things that are naturally spicy. Generally, the health benefits of those things are going to outweigh the potential risks of having some spice in your diet. Now, the spicy foods do tend to increase symptoms of heartburn and reflux, and potentially could loosen that sphincter a little bit. It's not entirely clear, and so everything in moderation. But I certainly wouldn't say the spicy foods are unhealthy, but like Dr. Wall said, in moderation, definitely.
Jason, public health, Hep C, talk about it. We're going to
Thanks,
deliver.
Dr. Christensen. I feel when I've been on the show, I always take this opportunity. Years ago, we had complicated, modestly effective treatment for Hep C. There is a lot of Hep C in our community, both urban in Twin Cities and in
You have 1 minute.
40% of the Hep C in Minnesota is in outstate, small towns, and so we have drugs now in 8 weeks. They're greater than 98% effective to treat Hep C, and so Hep C can lead to liver failure, death, and a lot of downstream health things. So, as physicians, we're aggressively screening people for Hep C. We have safe, effective treatment, and so if you think you're at risk for Hep C, see a healthcare provider, and we have a great treatment for you.
Your painter wants to know if artificial intelligence will solve some of these problems.
Like everything in life, it's a double-edged sword, and yes, it will, because our minds are fallible and the machines are a little more consistent. So they're going to pick up things, combinations. Just the other day, you'll see something with one lab here, a lab here. You weren't connecting it, but the machine is going to.
I want to thank our panelists. This was a great discussion. Dr. John Wright, Dr. Omar Siddiqui, and Dr. Jason Wolf, and our medical student volunteers, Alex Higgins, Andrew Middendorf, and Sean Morris. Please join me again next week for a program on lower GI problems, when my panelists will be Dr. Jonathan Gapp, Dr. Paul Sanford, and Dr. Adi Vittorio. Thank you again for watching. Have a great night.